Hi, my name is Matt Carlson, and I'm an Associate Professor of Otolaryngology at the Mayo Clinic in Rochester, Minnesota. I'm going to give you a brief overview of a study. The title is called Facial Nerve Schwannomas, Review of 80 Cases over 25 Years at the Mayo Clinic. And this will be coming out in an upcoming publication in the Mayo Clinic Proceedings. So the purpose or the goal of this study was to look back at our experience at the Mayo Clinic with facial nerve schwannomas over the last 25 years. The goals of the study were to look at clinical presentation and management strategy in a large cohort of patients. Facial nerve schwannomas are benign tumors that arise from the seventh cranial nerve. They commonly present with facial paralysis and hearing loss, depending on the location of where the tumor arises. In our study, we identified nearly 100 patients with facial nerve schwannomas over the last 25 years, and we ended up excluding about 20 patients because they had NF2 or they had incomplete data, and that left us with remaining 80 patients with facial nerve schwannomas, making it a very large series for a very uncommon or rare condition. Overall, the average age of presentation was approximately 45 years, and there were slightly more women compared to men. Some very interesting features or some findings that we found in our study that are unique or novel findings are first that facial paralysis with these tumors is more commonly occurs if there's involvement of the temporal bone, and specifically if there's involvement of the area of the temporal bone called the geniculate region, geniculate ganglion, or the tympanic segments of the facial nerve. This part of the temporal bone, the area of the bone where the nerve goes through, is actually more tight. And as the tumor can grow, it can actually strangulate some of the blood supply and cause pressure on a part of the nerve that can result in a facial paralysis on that side. Another interesting feature or another interesting finding that we discovered in our analysis is the fact that this is actually facial paralysis and facial spasm occurs more commonly in females. And I'm not aware of another study for facial nerve schwannomas that actually identified this. If you look at other literature and other disease processes, Bell's palsy occurs about the same in men and women, but it's interesting that Bell's palsy occurs more commonly during pregnancy. So it's possible that there's some hormonal driven influence that results in a greater risk of facial paresis or paralysis or spasm in facial nerve schwannomas in women. But of course, this is all speculation and would need further study. Another very interesting discovery that we had in our paper, and it also mirrors other papers in the past, is that because facial nerve schwannomas really can occur anywhere along the facial nerve, from the brainstem all the way to the terminal branches of the facial nerve in our face, the disease presentation is very much dictated by where it actually grows along the nerve. So under the microscope, of course, these are all histologically benign schwannomas of the facial nerve. But if the tumor arises at the brainstem, patients are much more likely to have different symptoms such as sensorineural hearing loss compared to if they presented with a neck in the parotid gland or in the neck. It turns out that facial paralysis is much less common when it occurs in the neck, and that's probably because the neck has much more distensible tissue and it doesn't become confined or constrained in a small bony area. So if it presented near the brainstem, these tumors are often initially diagnosed as or presumed to be vestibular schwannomas, which of course is another benign tumor in that area, but they're more common, so it led us to believe in some of those cases they were initially vestibular schwannomas and only discovered during surgery to be facial nerve schwannomas. And also when they occur in the neck, these tumors radiographically look very similar to parotid tumors. And so initially they were frequently thought to be a benign parotid tumor when in fact they were a tumor arising from the facial nerve. So the disease presentation is extremely variable and it depends on where they come from. Something that was reflected in our data that's also a very important I think, teaching point about these tumors is that they're commonly misdiagnosed as a Bell's palsy. And that's for several reasons. Probably the first reason is because Bell's palsy is much, much more common than facial nerve schwannomas. And so most of the time, if we diagnose it as a Bell's palsy, we're right. The actual mean time to first symptom onset in our patient population of 80 patients was about 22 months. So that means the first time they had a symptom, such as facial paralysis or hearing loss, it took almost 2 years before the diagnosis was made. And that's from the time of seeing the first physician anywhere to the time that it was actually diagnosed, usually by a specialist that specializes in treating facial nerve schwannomas. There's very key differences in how these diseases present to be able to distinguish them clinically between Bell's palsy and facial nerve schwannomas. And probably the biggest thing is of Bell's palsy, always occurs very quickly. So over the course of 1 or 2 days, the patient will say, I had normal facial nerve function and I woke up and my face was nearly completely paralyzed on one side. Or perhaps over 1 or 2 days. And patients often will also have sometimes ear pain associated with it and sometimes taste changes. And again, it's a very rapid onset occurrence with Bell's palsy. That is in contrast to facial nerve schwannomas. Facial nerve schwannomas have an insidious onset facial paralysis. So they'll say, you know, it was very subtle initially, but over the course of weeks or months or even a year, I noticed that my face has become more droopy on that side. Hearing loss is much more common to occur with a facial nerve schwannoma also compared to Bell's palsy. So it's these differences in clinical history that really allow us to say what patients should get more evaluation to determine if it's something else besides Bell's palsy. The diagnosis of these tumors is always made using MRI and CT together. And it's important that we don't just, when you're looking for a tumor like this, with a person with an insidious onset facial paralysis or other symptoms like this, it's important to get a fine-cut CT scan and MRI of the skull base. If you just get a thick-cut head MRI or things like that, you can often miss these tumors. They're often very, very small on initial presentation. It wasn't uncommon that we would diagnose a tumor here that was initially missed on outside imaging or something else like that because the tumor was very, very small and perhaps less than ideal imaging was obtained, thicker cuts. So that's another important point to mention. It's something that's also been reflected in our data set. The treatment of these tumors is actually evolved significantly over the years. So historically, when these tumors were initially diagnosed, they were often very large because imaging was not very exact before, and patients would have advanced symptoms. And because it was a long time ago, we didn't really know a lot about the natural history of these tumors, meaning what would happen if you left them untreated. And so historically, any time a facial nerve tumor was diagnosed, it was always resected completely. This is in the 50s, 60s, 70s, and even 80s, and even into the 90s. And we've learned over time, particularly with the advent of MRI with contrast, that a lot of these tumors are very, very slow growing, and that's significantly changed how we counsel patients and how we treat these tumors. So now we've kind of evolved from the primary goal of disease eradication or complete disease removal to function preservation for patients because these are benign tumors, they're not malignancies. And so our goal for most patients with these tumors is to preserve facial nerve function primarily as long as we can. In our series, we ended up having approximately 30 patients that were initially observed, meaning we made a diagnosis based on MRI and we watched them over time because they had very good facial nerve function. Just over 30 patients underwent some form of surgery. Surgical options for the treatment of these tumors include just decompressing the nerve, so we can actually remove the bone around it to give it more room to grow so it doesn't result in a facial paralysis as it grows. Another option is to remove part of the tumor, and this might be done for large tumors that are stuck to other important structures, or perhaps a tumor that's very, very large in a patient with normal facial nerve function. And we want to preserve that facial nerve function but still debulk a lot of the tumor because the tumor mass itself is causing problems. So that would be a subtotal tumor removal intentionally. Then the last treatment option for surgery is to actually remove the whole tumor. But because the tumor arises from the facial nerve, in general, removing all the tumor means we're also removing the facial nerve. And so generally we reserve complete removal for patients who already have bad facial paralysis because they're not going to be worse afterwards because they already have poor function. In those cases, removing the whole tumor is curative, and we'll often put a nerve graft in the intervening segment that's been removed with the tumor. And over many months and years, a lot of patients regain very significant function in that nerve, not normal, but recovered significantly. The last area of treatment that's also described in our series that's also very unique is the use of radiosurgery or radiation for treatment of these tumors. And really, this is a growing area of study. We have a very rare tumor that hasn't had a lot of history with treatment with this treatment modality, but our preliminary results are very promising. In total, we had 13 patients that were treated with radiation for their facial nerve schwannomas, and 11 of them had primary disease, meaning they never had any surgery or anything else before. And in 9 of 11 patients, they had tumor control, meaning after radiation, the tumor didn't grow or anything else like that. So in those patients, even though the tumor doesn't go away with radiation, we'd still say it was a success because the tumor didn't grow and cause other problems. One of the big questions, of course, is does radiation accelerate facial paralysis and all these other things? And it turns out that the answer is probably not in most patients. In our series of 11 patients who had never had any treatment before and who received radiation, only one person had facial paralysis in that group. And of course, the question remains, is that from the radiation, or is that just because the tumor was going to do that over time also? So at least our preliminary data suggests that radiation is an effective treatment for a select group of patients with these tumors also. I think it's a very interesting series in a large group of patients with a rare condition. I'd encourage you to look at our journal and read this publication if you have further interest.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.